Take it from Michele Neskey, the Posth PA and someone who has spent 20 years in oncology. Getting into PA school is hard, even harder than getting into medical school. But there are some days where getting in is the easiest part of becoming a great clinician. Because one day you'll walk out of a room where your bad news has changed everything for a patient and step right into the next like nothing happened. It's the same voice, the same presence. Today I'm talking to Michele, and she sees this gap all the time. So what are the students who actually thrive in this environment doing differently? Welcome to Shadow Me Next, a podcast where I take you into and behind the scenes of the medical world to provide you with a deeper understanding of the human side of medicine. I'm Ashley, a physician assistant, medical editor, clinical preceptor, and the creator of Shadow Me Next. I invite you to join me as we take a conversational and personal look into the lives and minds of leaders in medicine. This is Shadow Me Next with Michele Neskey, the Posth PA. Michele, thank you so much for joining us today on Shadow Me Next. You have dedicated your life to being a PA and now to helping multiple of the next generations of PAs at this point. Thank you for what you do, and thank you for sharing it with us today.
Thank you so much for inviting me. I'm excited.
It will be so fun. So you have worked as a PA for a few years now. Can you tell us about how long?
Yeah. This is my 21st year as a PA. I graduated PA school in 2005. So
Oh my gosh.
I can't even believe I'm saying that. It's so crazy. Yeah.
Absolutely incredible. And you really have flexed all the muscles of being a PA over those 21 years. Describe a couple of those roles that I think, as pre-health students, we always talk about. We love the lateral mobility. We love the fact that we can participate in politics and policy formation, all of that. Have you done all of those things?
Yes, in some way or another. I think, what I think is funny is we do talk a lot about the versatility and flexibility of moving through specialties. I personally have been in the same specialty for 17 years, but I did start off as a hospitalist medicine PA, which was like an inpatient job right out of college. So, and it was great because you know what? I didn't really know what I wanted to do. I had a lot of friends in PA school who were like, I want to do this. I day one of PA school, I'm going to be an orthopedic PA. And I'm like, I have no idea, I have no idea what I want to do. And so it was a nice way to learn from other PAs because it was a very heavy PA run service and be able to kind of see some of the other specialties and what I wanted to do. So then I moved to Miami with my now husband's residency for his residency. That's where I got my first oncology job. So I was in, internal medicine first. So
I think it's a really important thing to not specialize initially. And it's not everybody's story, right? But I was in GYN, which is generally, it's a pretty general specialty. And you're able to hone in a lot of those skills that you learned in PA school.
Yes.
And of course, oncology, really, you're dealing with all body systems in oncology.
Correct.
So, dermatology is a little bit different.
Yes.
We're very small
very
portion.
internal medicine heavy, very internal medicine heavy. Here's what I knew I didn't want to do. So for me, I was like, I am not for surgery. Okay. It's not for me. And I am not for, unfortunately, like OBGYN. I passed out twice in the OR during OBGYN. I'm like, this is not for me. So there were things like I knew I didn't want to do. And I think that that's always good too. You don't really think about that. It's like, here's what I know I don't want to do. And then, kind of move on.
And, it's so funny you mentioned surgery because you also mentioned your husband's residency in Miami.
Yes.
He is a surgeon.
Correct.
And you were like, absolutely not for me at all.
Yes. He is a head and neck cancer surgeon. Long surgeries, very detailed, he's very tactile. I have, he always says I have floppy baby hands, we're very different in that kind of way. But yes, it was a very interesting journey for us. I met him before I went to PA school and before he went to med school. And so he got into med school first. I got into PA school a year later, in different states. So,
oh my gosh.
Yes. So we did a long distance relationship for 4 years, essentially, through PA school, through med school, and then got married and moved to Miami for a residency. And we're both from the Northeast, so it was definitely a big change, and there's definitely challenges in that, but I think ultimately that's what makes us like our marriage kind of stronger today, because there isn't anything either one of us won't say to each other at this point.
Hmm. Hmm.
Very open communication, very honest, about where
Yes.
we were with things. And, it's definitely an evolution for sure, but it can be done. So.
Absolutely. So very similar. I mean, similar. I'm sure in head and neck ENT, he gets a lot of cancers as well, and you do a lot of oncology. Do you guys talk shop at home, or does work stay at work?
Sometimes
Hmm.
we've shared patients. So
Oh
we
wow.
formerly, yeah. So we used to work at, so when he did his residency, we were not at the same hospital. But when he did his fellowship, and then when we moved to South Carolina, where we are, we worked in the same hospital. And he's basically surgical oncology, and I'm medical. So
Right. Right.
we would share patients in that way. And so that was kind of fun. We don't work directly together, right?
Right.
But like we share that patient. So I'm like, oh, you saw Dave, so that's kind of a fun thing. We don't work at the same now, but we still kind of share some patients ancillarily. We don't talk a lot of shop at home,
Yeah.
um, especially he doesn't want to,
Yeah.
you know. However, when we have a bad day, or when we like, there's been a really hard patients or
Hmm.
whatever it is, it sort of is like, you don't have to talk to me today. Like, I get
Hmm.
it. You know what
Yeah.
I mean? So,
Yeah.
like, that's kind of a nice understanding that we can support each other through that. And sometimes that just looks like, let's just talk about anything else,
Hmm. Hmm.
So
Hmm.
we don't talk a lot of shop at home. So, which is good.
No, it does. And it's such an interesting distinction because as I tell people, we pick being a PA for the lifestyle. And a part of the
Correct.
lifestyle is who you're going to spend your life with, right?
Right.
And my husband works in finance, and
Yeah.
I come home and I start talking to him about the holes that I have made in people's faces. And he says,
Yeah.
Ash, I love you. I do not love the words that are coming out of your mouth right now. Please be quiet, and I said, okay, like let's change the subject, but just,
Yes.
that's why I'm a little snippy.
Yeah.
I had a silver dollar size hole in somebody's nose today, and it just
Yes.
didn't look like I wanted it to look at the end, so,
Yeah.
so it's very interesting, when looking at these careers, it's sometimes it's a group decision,
Yeah.
and sometimes it's focusing on what your life is going to look like 10, 15, 21 years from now.
Yes.
You mentioned something that I want to touch on quickly, and that is medical oncology and
Yes.
surgical oncology. Could
Yes.
you give us a little definition and maybe
Yes.
explain the differences of those?
Yeah, absolutely. So medical oncology, so there's three branches of oncology: medical oncology, radiation oncology, surgical oncology. Medical oncology is we give all the treatments that are IV, oral, any type of infusional therapies. So chemotherapy, immunotherapies. You see a lot of them on TV, right? Like a lot of
Mm-hmm.
the things on television that you see for any type of cancer. We also do hematology. So
Okay.
it really just depends on what practice you're in. But medical oncology, you can either be hematology oncology or just med onc. So
Okay.
hematology oncology means that you do both benign blood disorders and cancer.
Mm,
Medical oncology means you're straight up cancer, no hematology problems or anything like that. But really, we are the ones administering um, any kind of medication, to a patient for cancer.
mm,
Surgical oncology, clearly they are the surgeon, so they're doing the removal of any cancer, either curatively or just to take it out for pain purposes or
mm-hmm.
whatever it might be, more palliative. So they take care of the whole surgical aspect, and then radiation oncology is obviously giving external beam radiation or proton radiation therapy to specific areas of cancer. So the biggest difference between medical oncology and both surgical and radiation oncology, those types of therapy are really for localized cancers,
Mm-hmm. Mm-hmm.
right? Like you have a spot here, let's radiate it.
Mm-hmm.
You have a tumor here, let's take it out. Our treatments are systemic. So they're
Mm.
going throughout your whole body. So while we do give treatments to people who've had surgery to prevent recurrence, we also give treatments to patients who have metastatic, somewhat incurable disease. And so that's really what the differences are.
Incredible. And then in medical oncology, which is where you practice, the end goals are a little bit different for each patient,
Correct.
right? So we all like to think if we have cancer, specifically metastatic cancer. We're going to go in, they're going to give me chemo, my hair's going to fall out, I'm going to feel like crap, and then I'm going to get better. And we
Mhm.
have seen recent studies that have come out that have shown that, yes, we are making major advances in
Yes.
cancer survival rates, but the end goals for patients aren't always the same. Can you tell us a little bit about that?
100%. So,
Mhm.
sometimes we are treating patients for cure. We're
Mhm.
giving them chemotherapy or immunotherapy to cure them, so meaning after surgery, or maybe they have a type of cancer that doesn't require surgery, like
Mhm.
lymphoma, for example, where you can cure with chemotherapy, right? And biologic therapy. And so some patients, we are going for it, like we're going for the cure.
Yes.
Other people have had their tumors removed, and we're giving chemo as an insurance policy
Okay.
to help reduce the risk of cancer recurring, right? We can't say that this treatment will 100% do that, but we have studies that say giving you this treatment after your surgery reduces your risk of recurrence by this much.
Mm.
So most people will go ahead and do that, then they go off treatment, and then they go on surveillance. And then we do have other people who are being treated for, metastatic cancers or incurable cancers, technically. And sometimes their outcome is to just improve their quality of life,
Mhm.
quantity of time here with their
Mhm.
friends and family, keep the cancer under control, and have them living as normally as possible for as long as possible. Whereas other times we can really transition people with metastatic disease into a maintenance mode, depending
Mhm.
on what type of cancer they have. And they may not need to be on therapy their whole life. But what we're seeing now with some of the immunotherapies is that after 2 years, if you've had a response, we can stop. And even
Wow.
talking about metastatic disease and 2 years of no cancer is crazy.
Yeah.
Like, I just think back to when I started this, and it was like, that was unheard of. Like, specifically for lung cancer and like things like that, right?
Yes.
So,
Melanoma. Yes,
yes,
absolutely.
melanoma, like all these. So we've come a very long way. So it really depends on the patient, the type of cancer, and what the goals of care are. So,
And we that was the science, and as PAs we love the science, but of course
mhm.
we love the humanity in medicine too. And I would
Yes.
imagine that the conversations that you're having with all of those different types of patients are very different conversations.
Yes.
How do you navigate that? How do you wear one hat and then take it off, and then the next room you wear another hat, and then what does that look like?
You have to sort of treat every encounter as its own, if
Hmm.
that makes sense,
Hmm.
right? So you can't bring what you just said in another room into the next patient's room. And if you have to take a second, you have to take a second, and
Yeah.
it's fine. And most people will understand that. Most patients will understand that. And so but you have to also, it's okay to do that when you're in the middle of a busy clinic and things like that. But at the end of the day, you do have to process those things,
Hmm.
because if you don't, they do build up over time and cause a lot of emotional stress and burnout. So I think what's important about that is every patient is its own encounter,
Hmm.
and I am there to help them get through whatever situation it is. It is not about me. Like, it is about them, right? So
Yes.
if it was a hard conversation, it was triple as hard for them to hear than for me to deliver. And so I always remind myself that that was harder for them than it was for me, even though it was hard for me.
Hmm.
And I have to go help the next patient and meet them where they are. And that's, I think, the most important thing. Also, gauging the patients. So, first of all, like you said, oncology is a very relationship heavy specialty, which is what I love about it. We see
Right.
patients every 3 weeks, every 2 weeks, every 6 weeks, every whatever. And like, you get to know them, you
Oh,
get to know
yeah.
their families, you get to know their history. Some people are super interesting, and you've connected with them. So if you have to deliver something that's, you know, um, technically bad news or whatever,
Hmm.
it's a little easier because you have that relationship, and you can kind of say, I really don't want to deliver this, but like,
Yeah.
here's what we have to talk about. Whereas if you're trying to do it with somebody brand new, it's definitely a different conversation, and you just have to
Mm.
read the room, and you have to read your patient, and knowing their education level, number one, number two, what information do they want to know,
Hmm.
and how can you work together to make that process as smooth as possible. So
Yeah.
yeah.
Yeah. I mean, and we're on such a sad topic right now, but
Yeah.
unfortunately this is a case. People do get quote unquote bad outcomes, and you do have
Yes.
bad news. But like you mentioned, I mean, in the last 20 years, advances in cancer treatment are
Unreal.
just, they're mind blowing. Tell
Mhm.
me about something recently that is you're just so proud of in the cancer community that we have and that we have available. Maybe in an anecdote if you have one.
Yeah, so, I think some of the biggest shift in cancer treatment came with the advent of immunotherapy and
Mhm.
biologic therapy. So just so you know, immunotherapy is either IV or injectable at this point. And what it does is, not to go kind of too geek on this, but
We can geek out.
it stimulates your immune system to fight the cancer.
Yes.
So these drugs, as opposed to chemotherapy, where we're just literally killing DNA of cancer cells in
Mhm.
any way possible, and all your other DNA too. So, I mean, so that's why there's sometimes a lot of side effects from that. Chemotherapy is still a very strong backbone for a lot of our treatments. And just to sort of, you said this in the beginning, people have a very negative outlook on chemotherapy.
Mhm.
We've come a long way with chemo,
True.
okay? Because we've come a long way with pre-medications. So
Mhm.
not everybody loses their hair.
Mhm.
Not everybody throws up all the time. Actually, I rarely have a patient vomit,
It's
ever.
amazing.
So think about back in the day when people were like, you're going to lose your hair, you're going to be sick all the time, you're going to be all thin and skinny. Like, some people do have side effects like that, but I can say, like, with authority, that very, very few of our patients vomit. So, I
Incredible.
mean, we could have nausea, but not a lot of vomiting. Not everybody's losing their hair. So I think that's an important thing to know. Every chemo
Mhm.
regimen's a little different. Um, but immunotherapy really kind of changed the game,
Mhm.
and it's approved for a lot of different treatments. And I think, to me, I have a soft spot for lung cancer. I did I worked in a community oncology practice first, which just means it was a smaller, like, outpatient office connected to a hospital that had a few physicians, and we did heme and onc, and so we saw all diagnoses and all of that. And the physician that I primarily worked with had a specialty in lung cancer, so I kind of started learning about it there. But then when Dave went to fellowship at MD Anderson, I worked in lung and head and neck medical oncology only. So talk about the different, like,
Wow.
things. But I will say this, we have two patients I could name off the top of my head who had metastatic lung cancer, who got immunotherapy for 2 years, have been off treatment for at least 2 years, and are disease, no disease,
It's unreal.
none. Like stage 4 lung cancer, like, and there's a lot of nuances that goes into that. Not every stage lung
Sure.
cancer is the same. A lot of markers and predictors, and that's also a huge advancement. All these markers we can test for now in tumors to see if this medication will work for you, right?
Mhm.
So
Mhm.
just such a shift of it's much more of a personalized regimen rather than before, where everyone just got this. Now it's like, this isn't going to be a good for you, you're going to get this. So it's definitely more driven to the patient's specific pathology, genetics, all of that kind of stuff, where we're really trying to make it more personalized. And I feel like it really has come that way. But those patients that I see, I'm always just like, wow, like, this is crazy,
Yes,
So,
yes.
yeah,
Once upon a time, we would have
yeah,
called it a miracle, is what we would have called
correct.
that,
Yes,
right? I have a similar melanoma patient who had melanoma of the skin, which metastasized to melanoma
yes,
all over, brain mets,
yeah,
multiple. And every time I get a note from his medical oncologist about a clear scan, I have to smile first. It really
yes,
does make you smile. And
yes.
it just blows my mind. Michele, you are incredible. The fact that
Thank you.
you have worked in oncology for this many years is just mind boggling. And I'm
Yeah,
so grateful for your service there. But
thank
that
you.
is only half of what you do,
I know.
which
Yes.
is even crazier. So if you are listening to this and you're thinking, dang, Michele is so cool, I want to be a PA, where do I start?
Mhm.
Well, we will tell you where to start, and that is micheleneskey.com,
Yes.
Micheleneskey.com. Michele, tell us about some of the amazing resources that you
Yeah.
have on your website.
So, I had my daughter in 2014. I went back to work and really enjoyed it, but I have a surgeon husband who's super busy, and we kind of felt like I was like, I'm at the point in my career where maybe I can create some flexibility from
Hmm.
home. What can I do? And it started as a blog. It started as a blog, not even to like help preview. Remember blogs? I
I
mean,
do.
that feels like now, everyone right now is posting about 2016. Yeah, I had a blog.
On
Okay.
a blog.
And it wasn't even a blog about PA school. It was like a blog about me and Dave, like how hard it was
Wow.
to be married to a resident and like
Yeah.
that kind of stuff. And then I had some students come through and clinical research coordinators that I worked with who wanted to go to PA school. So I just started
Hmm.
helping them, I
Hmm.
just started helping them kind of navigate through it. And I was like, this is really fun. Like there could be
Yes.
something here. And just like word of mouth and boom, like 2019, I'm now like a pre-PA admissions coach, and I've been doing it since 2019. So what I do and what my other PAs who are on my team do is we really navigate the process of PA school applications, and it's very confusing and
Hmm.
it's
Hmm.
very challenging. And every year it gets more and more competitive, and there's more and more components. And I think the biggest, people ask me this a lot, is it harder to get into PA school than it is to get into medical school? The answer to that is no.
Hmm.
It is harder to apply to PA school because of the variable prerequisites and requirements from program to program. And that's where we really help people navigate through that. But then we
Perfect.
also help them with their essays and how to shine in their essays, making sure they're not making mistakes on their application by reviewing them. We mock interview people just to prepare them. If they get the interview, like you have a 1 in 3 chance of getting in, so let's nail it. So we
Yes.
practice with them, as much as possible, and it's been amazing. It's been so rewarding. Did I ever think I'd have all these followers on TikTok and Instagram, and no. And also, like you know I remember so vividly going through this process by myself with no medical people in my family at all. And
Wow.
when I did it, oh my God, this is great. It was like the first year of CASPA. So there was like maybe like 30 schools, and the rest were paper.
Stop
Fun.
it.
So I had like paper stacks, and I was like, this is bad now, but at least it's not paper. Like it was like, so I've learned so much, about the admissions process over the years, and have friends and colleagues who are former program directors on my team and admissions directors on my team that have like opened my eyes to some things too. So it's been awesome. So now I work clinically 2 days a week, and I do the Posh PA for the remainder of the time, and it's fantastic. So
Absolutely incredible. Yes. And you've amassed a massive following on TikTok and Instagram and YouTube. And it's because the content is stuff people want to hear and
yeah,
need to know, right? I mean,
right.
you've nailed both of it, and you do it in such a fun, engaging, and
Yeah,
exciting way. And obviously, that all just comes back to the fact that you love being a PA.
I love it.
And
I
it,
love
it
it.
it is it's the job. I mean, it is just the job. So if you guys who are listening, it's going to be Michele.theposhpa, Michele.theposhpa. That's on Instagram and TikTok. You can find her on YouTube at the Posh PA, and check her out on LinkedIn too. She's there at
Yes.
Michele Neskey. You
Yep.
are incredible. Thank you so
Thank
much for spending
you.
time with us. Thank you for
Thanks for
creating this
having me. This is so
amazing
fun.
resource. It's been a
Yeah.
blast.
Thank you.